All right, I think we'll go ahead and get going. This is going to be recorded, I believe, correct, Brand? So, and if you guys want to view this at a later time, obviously you're welcome to do that. So this is a different format than we've done in the past. We're just starting this format. Basically, we're going to be using scanned slides of unknown slides that we've circulated to various groups. And so basically, we've just scanned those actual slides. We're going to go over those. In the future, I'll probably be adding some Codachrome clinical information to these. In the past, we've just done these as pure Kodachromes, but now we're actually doing slides. And this is probably better for you because on the board, this is the technique that you're going to get. They're going to scan a slide in. They're going to have you use a technique to look at it on a computer or a tablet or something, and then you'll be scrolling it up and back. So this is really more kind of what you're going to see on the board. So I think it's it's analogous to looking under a microscope. It's not exactly the same thing, but it's similar. And so what we'll do is we'll go through, I think we're going to go through 15 cases today in about an hour, and then we may in the future cut that to 10, but we'll do this probably every couple of weeks. And we're going to incorporate these kind of unknown sessions in with some more didactic, straightforward talks that are more thematic, that we're in the process of kind of finalizing that. So for those of you who want to kind of participate in this in an interactive way, you can kind of go on the chat and kind of post your thinking there if you'd like. Otherwise, you're just welcome to sit back and just kind of watch what we're doing here. I would recommend that when you're doing this on your own, that you do test yourself and that you do this like we do it under the microscope here. We look at everything without any information. We apply the criteria. We come up with a differential diagnosis, and then we correlate that with clinical information and try to make a final diagnosis. So here we have a punch biopsy, and we see it's of an inflammatory disease. There's really no neoplastic anything in here. And a low magnification, you can see it's got this superficial and goes all the way down to the bottom, perivascular, but also largely interstitial. And if you look at the shape of the biopsy, here we have two different pieces of it. You can see it does have kind of this almost kind of boxy, squared off morphology to it. So at low power, you say, well, there's some dark cells here. There's probably going to be some lymphocytes in there, and we've got a higher magnification. And the fact that there's a significant interstitial component is a very important part of the differential diagnosis here. So there's really not a lot of diseases that give interstitial, mostly inflammatory patterns. And so just like we talked about in the introductory lecture, you want to ask yourself what kind of cells are in here. And here they happen to be lymphocytes and some plasma cells, and also in some areas there may even be some eosinophils. These little aggregations here are lymphocytes and plasma cells, which is important. And then if you look at the collagen bundles, so let's look away from the inflammation for a minute, and notice that they're increased, they're thick, there's a decrease in the number of fibroblasts. Most of these are inflammatory cells here, and there's a suggestion of some homogenization of the collagen bubbles here. So when you see those features together, that is what we call sclerosis. So we have sclerotic collagen. We've got a perivascular but more interstitial pattern in this situation. And then we also see that kind of squared off biopsy, and we also notice there's really nothing involving the epidermis. So this is an example of the inflammatory stage of morphia. And morphia is one of the conditions that can give you an interstitial mostly pattern. So some other things that can give you that, interstitial form of granuloma annulare, that can give you histiocytes mostly interstitially, cellulitis, erysipelas, that can give you a mostly interstitial pattern. And then there's some neoplasms that can give you a mostly interstitial pattern, things like leukemias when they spread to the skin, metastatic breast cancer, Kaposi sarcoma in the patch or early plaque stage can give you an interstitial mostly pattern. So when you see that pattern under low magnification, think about this relatively limited differential, and then ask yourself what the type of cells are. Make sure they're not neoplastic cells. If they're lymphocytes, plasma cells, and then eosinophils, and then of course with this collagen change, you can think about the inflammatory stage of morphia. Now, one other kind of point about morphia If you get it really, really early, even earlier than this, and we don't really have any subcutaneous fat here because this was probably a fairly thick sclerotic plaque that was biopsied. If you get the very super earliest stage when the skin gets edematous overlying your hands, it gets kind of puffy, that just gives you some kind of an edematous stroma, edema of the septum subcutaneous fat with some mucin deposition a little bit. So that's what you see in the real super earliest stage of morphia, even before you get any collagen changes. So hopefully you all were able to at least come up with that differential diagnosis and think about that. That was the diagnostic answer in that case. So here we've got another, looks like a little punch biopsy again. Pretty little smaller specimen. So I can move away from that one that's got that big tear in it. Okay, this is a better sample here. And we see here a low magnification. Once again, we got an inflammatory process, and there's very, very little going on here. And so you're probably not going to be able to make a diagnosis on something like this without some clinical information. So if you just look at this alone without anything, you say, well, it just looks like a very sparse superficial perivascular dermatitis. And that's the most common histologic inflammatory reaction pattern that we see. And there's really a very limited amount of inflammation, just a very sparse amount of a few lymphocytes up here. The cornified layer is a little bit thickened. It's basket weave, so it's not totally thick, compact cornified layer like you would see just with pure lichen simplex chronicus. And we've got a little higher magnification, basket weave cornified layer, maybe a tiny bit of spongiosis here and there, and a sparse infiltrate of lymphocytes. So if you had a multiple choice type of question here, because that's, or they would give you some information, maybe they'd say this is a 70-year-old person that came in to see you with some itchy skin, and they admitted to bathing twice a day, and it was in the wintertime, and this biopsy was taken, what would be the best diagnosis? And if they put things in there like allergic contact dermatitis, that really wouldn't be the best diagnosis here. If they put nummular, if they put an acantholytic process, say Grover's disease or something like that, none of those would be really very good answers. If they put asteatotic dermatitis or xerotic dermatitis, that would be the best answer, because that's actually what you see when you biopsy asteatotic dermatitis. It really looks pretty much almost like normal skin with maybe a little bit of lichen simplex chronicus and a little bit of spongiosis. Sometimes you get a little bit more spongiosis than you see here. You will never see true spongiotic microvesicles. You can see a little bit of spongiosis, and sometimes you can see a little bit of parakeratosis with a little bit of crusting. But this is one that does not show pathognomonic findings. It just basically shows what you would see in an example of asteatotic dermatitis. Now, what else could give you this pattern? Well, if you had a subtle manifestation of say, atopic dermatitis, that could look like this. A drug eruption, drugs can do anything, so that could possibly look like something like this. It'd be a sparse drug reaction, maybe a viral exanthoma. But because those all look pretty similar, they're not going to put something like that on an examination and expect you to basically sort them from one another. If you had a pattern like this that had a lot of eosinophils in it, or something like that, maybe if they had a PAS stain and maybe it showed some spaghetti and meatballs in the cornified layer, well, that might be obviously Tinea versicolor. But when you're looking at these sparse superficial perivascular dermatitis, the key is just to know what other elements you look for to try to make a more definitive diagnosis. So again, if you saw more spongiosis, maybe you throw it into one of the other spongiotic dermatitis categories. If you saw some eosinophils, maybe think about a drug reaction or some kind of hypersensitivity reaction. If you just see something like this, it's pretty nondescript. And asteatotic dermatitis, if it was a choice for you, would certainly be a reasonable thing to think about. Okay, let's move on to this case, which is diagnostic. So if you've had a chance to look at this one, this is one that hopefully you would be able to kind of get without even any history. But it does have a differential, so we can learn from it. So this is a punch biopsy, and this time we have a neoplasm. And notice at low magnification, it's pretty vertically oriented. When we see that, we think about a benign process. If you look at the symmetry, it's really quite symmetrical. And so at low power, seems to be small, symmetrical, well circumscribed. We favor a benign process here. So the next step is we ask ourselves what kind of differentiation is exhibiting. Is it epithelial or non-epithelial? Let's go to higher magnification. It certainly doesn't look like a typical epithelium. Certainly doesn't look like the epithelium, say, of a hair follicle or of the overlying squamous epithelium. Doesn't look like any adnexal structures. And it's got all of these central spaces in them. And if you look at those little spaces, they are lined by these flat cells here. And then you've also got these very round, homogeneous cells that pretty much look kind of like cookie cutters. They look one like another, clonal, if you will. So a dilated with some extravasated, well, some not extravasated, but the red cells inside these spaces here. So when you put all that together, you might say this is probably a vascular neoplasm. And then when you, the next thing is to say, well, does it look like a typical cherry hemangioma, for example? Well, no, it really doesn't. It's got all these additional cells in it that are round. They're very homogeneous, look pretty much one like the other. And so you might be thinking of like a cellular vascular lesion. And when you see something like that, you could say, well, it's in the family of the hemangiomas, but because these cells do look very round and they look very much like one another, that's very classic for when we think of glomus lesions, glomus tumors. And when you have a glomus tumor that's got these large ectatic blood vessels, we call that a glomangioma, as opposed to a solitary glomus tumor, which is much more solid, much more cellular, kind of a compact lesion with smaller numbers of ectatic blood vessels. So a solitary glomus tumor, which is commonly seen in the nail unit, painful lesion, would not give you these large ectatic blood vessels and these multiple nodular kind of aggregations. So if you go down to this area here, here's another aggregation of this. So these often have 2 or 3 or 4 individual little neoplastic, aggregations sort of clustered together. So this is an example of a glomangioma. Now, if the board might ask a question about the glomus body, hopefully you know what those are. These are structures that regulate blood flow, usually in acral parts of our body, like the digits. So when you get really cold outside, your fingers get white. If you have Raynaud's disease, your skin gets really white in the cold. And that's because the glomus bodies in your fingers contract, and it shunts the blood out of your fingers into your core. So your body temperature doesn't go down. The blood temperature and the body temperature in your acral skin can go down pretty significantly before you get frostbite or anything like that, but you can get really cold hands, but you still have, thank goodness, a warm heart. So you don't want to get your core body temperature too low because that's obviously life-threatening. So the way that those glomus bodies work is that these are myoepithelial cells. They actually would stain positive for smooth muscle actin. So these cells actually have actin filaments. They constrict. They cause the blood vessels to constrict, and then basically your blood gets shunted into the internal part of your body from your external part of your body. So that is a glomangioma. Hopefully everybody got that right, because that's one that is typical good potential board fodder. So that's something that you could be asked about on the examination. Okay, let's take a look at these 2 little pieces over here. There's not any artifacts here to speak of. And we've got a low power view. We've got a nodular infiltrative cells here. Okay, so nodular dermatitis, remember that's one of the patterns of the inflammatory skin disease that we look at. And if you look at this power, you can say, gosh, we know these are not all going to be lymphocytes because this is not jet black here at low power. So if this were a pure lymphocytic infiltrate, this would have, all these cells would be very dark. And notice that there's a small zone of pallor just beneath the epidermis. You all know what that is. That's a so-called Grin zone. And if you look at the body location, it's kind of hard to be sure where we are, but this might be near the face. It's not on volar skin, that's for sure. And most of the inflammatory infiltrate may have wiped out, say, any sebaceous lobules, but there are some, minor, little miniaturized vellus follicles here and some sweat glands. So let's just say that this is maybe it's on the cheek. Maybe it's not on the nose. There's a lot of sebaceous lobules, but it's maybe on, let's just say for the sake of argument that it's definitely on the face. It's not on acral skin. So we got this nodular dermatitis. So the next thing I want to look at is the type of infiltrate here. We know it's not all lymphocytes. And as we go to even more higher magnification, we notice, aha, it's got the cells that are both neutrophils and also eosinophils. And we have these blood vessels over here. And in some areas, we even see some, looks like an increase in the amount of collagen possibly surrounding some of these blood vessels. And even some of these neutrophils are kind of broken down. So we've got some leukocytic we've got a nodular dermatitis. It could be the face, and we'll say it's on the face or near the face. And it's also got eosinophils. So what's the diagnosis in this situation? Well, this is an example of granuloma faciale. And this is an example of granuloma faciale is a nodular dermatitis. It's a form of vasculitis. So it's a chronic nodular form of vasculitis. That's not nodular vasculitis, the diagnosis nodular vasculitis that is used and synonymous with erythema induratum, which is associated with microbacterial infections and things like that. But it is a nodular infiltrate that shows a chronic vasculitis. And there's two conditions where you see this. You see it here in granuloma faciale, but you also see it in erythema elevatum diutinum, which is a histologic identical twin of granuloma faciale. So if you were, going to get this on a board examination, they would not show you erythema elevatum diutinum as a differential diagnosis. It really wouldn't be fair, but they might show you, they might put on the list a pseudolymphoma, lymphocytoma cutis, which hopefully you would not choose in this setting because that does not have neutrophils, does not have any form of chronic vasculitis. That's basically a nodular infiltrate with lymphocytes and eosinophils and germinal centers. So that would not be a good choice here. It's not a classic example of just garden variety leukocytoclastic vasculitis either, because that doesn't give you this dense nodular infiltrate like we see here, even though this is considered to be a form of long-standing chronic vasculitis. Now, if this stays, if it's there long enough, it eventually can lose some of the inflammation and become more fibrotic, and you'll see this almost onion skin-like fibrosis around these blood vessels. So you're seeing a little bit of that happening right here in an early stage. If this disease, if this lesion were present, say for maybe another 6 months or a year, you might see less inflammation and more of that onion skin fibrosis, and that's really commonly seen and more commonly seen, I'd say, in erythema elevatum diutinum than in granuloma faciale, but it can happen there also. We see these lesions clinically. That's one of the reasons that in the future we'll probably be putting some clinical slides in here also. You'll see this brownish peau d'orange appearance on the face. And they really get that peau d'orange morphology. The pre-existing adnexal structures are preserved. They're not destroyed, but they become patulous. And that's a very characteristic feature of this disease. And you don't really see that in a pseudolymphoma. So if you see something clinically that's brown, it doesn't have any scale because there's a Gren zone here. The epidermis is not involved. You get these patulous ostia. Think clinically of granuloma faciale. It's not really granulomatous. It was actually named that because years ago it clinically looked like a granuloma. So that's something to remember there too. It's not really a granulomatous dermatitis. Okay, so here, look at this one's a beautiful little biopsy here. And we've got a lesion here that is obviously a epithelial process. And what kind of epithelium are we dealing with? Well, we're dealing with basaloid epithelial differentiation. What is basaloid differentiation? Okay, so it is a type of epithelium. It's really follicular. So think about the hair follicle again. You've got the infundibulum that looks like a funnel, an isthmus, and then you've got the isthmus beneath that, and that's kind of where the mantle zone lives. That's where a lot of the stem cells live. And then you've got the inferior portion of the follicle. And the inferior portion of the follicle, which is where the stem cells of the base of the follicle producing the hair shaft, those are the same type of cells that live in the mantle zone. So when the follicle undergoes its cycling and it goes from anagen to catagen to telogen, and it kind of goes in that resting stage, those cells that live in the mantle zone are the ones that sort of give rise to the new follicle when it goes back into anagen. So you can get neoplasms that look like the inferior portion of the follicle from that mantle zone. So those are kind of analogous to one another. So this is developing a primitive basaloid differentiation, and it's either mantle zone or it's inferior portion of the follicle, not infundibulum, and not really the isthmus. The isthmus is where you get kind of a glassy appearance, and isthmus catagen cysts, which is the catagen part of the follicle, when it basically contracts, you get that thick, glassy, eosinophilic basal membrane zone-like morphology. That's what you see in the center of tricholimal differentiation and tricholimal cyst. So that's not what we have here. Here we've got inferior portion, or we've got mantle zone. So we've got basaloid cells. So we've got a fairly prominent stroma. We really don't have clefting here. So we've got a neoplasm that's a primitive follicular lesion. So how do you name those lesions? Okay. Well, Dr. Ackerman years ago just decided he was going to call basically all of them trichoblastomas. And so this does have a lot of trichoblastic morphology, meaning blast, cell of origin of the follicle. So it's an interesting name, and I think it's reasonable to consider that entity here. If you wanted to segregate this out, you might say, well, is it a type of basal cell carcinoma with trichoblastic features? Is it just a trichoblastoma? It sort of gets more of a semantic issue. So this was diagnosed as possibly a basal cell with trichoblastic features, but it's really more of a trichoblastoma. And a lot of these lesions behave like low-grade basal cell carcinomas. So when you get one of these lesions diagnosed clinically, we usually recommend re-excising them, because they can come back and they can ulcerate, and they usually never spread anywhere else in the body. These usually don't get really deep into nerves and do bad things like that, but they can ulcerate and they sort of behave like a basal cell. So we usually recommend re-excising them. But just the most important point is to understand that this is a primitive follicular differentiation. And these are some little papillary mesenchymal bodies. Here's kind of like a little hair papilla, and it's forming a miniaturized follicle here. So again, I wouldn't really think this is a classic basal cell carcinoma. To me, this is more of a trichoblastic lesion, and maybe we would treat it like a basal cell carcinoma. So hopefully you all learned something from this. It's not a classic trichoepithelioma. Those usually have even more well-defined hair follicles and more papillary mesenchymal bodies. They don't usually have these large aggregations like this that are somewhat slightly asymmetrical. So this would not be a classic trichoepithelioma. We would call this more of a trichoblastoma, more primitive than a typical trichoepithelioma. Okay, so hopefully everybody got this. Now this case here is really a very good learning case here. We'll look at this lesion, this one here. You see we've got several different pieces of this. So they actually took, that one's actually got a little tear in it. Let's see if we can find another one that's a little better. Well, maybe not. Look at this one here. So we got a shave biopsy. Okay, and we don't, unfortunately, this is a dangerous type of situation here. So this lesion was really not diagnosed clinically by the dermatologist. They didn't really know what they were dealing with. But we've got some type of a neoplasm going on here, and it's really kind of not easy to tell what kind of differentiation it's giving here. It's got zones here where the cells are kind of formed a coalescent aggregation here. We've got some other areas over here where there's some clear areas, but are those artifact or are they real? We've got some red blood cells over here. We don't have any involved in the epidermis. So we ask ourselves, is it benign or malignant? We've got a shave. We've got a shave of multiple pieces. So maybe they took 3 or 4 pieces and put them in the bottle together. Maybe they wanted to kind of give kind of a scouting biopsies for us to kind of give us an idea. So whenever you get something like that, you say, well, maybe this is a piece of something bigger. So we really can't assess size based on this. We don't know if this is really representative of the entire process or not. So we can't use size. Can we use symmetry? Well, it doesn't look too symmetrical here. We just got a little dome-shaped papule, but this area kind of looks different, and there's nothing here, and there's got this funny area over here. So, that's kind of a little bit of a red flag. So we can't assess size. We get a little bit question of symmetry, breadth, size, symmetry, circumscription. We really can't tell much about that. It certainly goes to the bottom of the side. So we're kind of hamstrung a little bit here. So we're gonna have to use ancillary feature. We're gonna have to look at higher magnification. When we go to higher magnification, you know, we've got these areas over here, and maybe these are an artifact. There's some stuff that's floating in these spaces over here. And we've got these little villus fronds, and we've got these cells that are floating freely within these spaces. So whenever you see something that looks clear, and you say, is this an artifact or not? If there's something in the clear space, it means no, it's probably not an artifact. So if it's got blood cells in there, if it's got inflammatory cells, if it's got neoplastic cells floating in those spaces like we have here, well, then the bad news is that it's not an artifact. And when you start looking at higher magnification, you see these cells are not very typical in their appearance. This has a hyperchromatic nucleus. I mean, this one's got sort of a bizarre, almost kidney-shaped nucleus. And this one's got some vacuoles in here. You may even see some cells that are in mitosis within this area. And then we've got these little sort of frond-like villus structures that are lined by those cells. So we see something like that, we say, gosh, you know, things that give you clear spaces in the skin, well, what can cause that? I mean, can it be a blister in the skin, like a blistering disease or something like that? Or can it be like a vascular space? And here, when you've got these irregular staghorn, bizarre spaces like this, that's classic for an angiosarcoma. So this is a shave biopsy of an angiosarcoma. And we're going to look at a couple other areas. If we look over in this area, a little harder to appreciate that it's vascular when the cells become, when it becomes really confluent like this. So, you know, angiosarcoma can be solid and nodular areas like you see here, in addition to the vascular areas. And sometimes when you see a field like this, it almost looks like an epithelium. So if you just had a high power view of this, you say, is this epithelial or non-epithelial? You wouldn't really know for sure. And there's a type of angiosarcoma that can be epithelioid, meaning it looks like an epithelium, but it's really not an epithelium. And that's actually, if you just have this sort of focus right here, that's an example of what we're looking at here. So this is an example of a so-called epithelioid angiosarcoma in this area that has areas in which there are blood vessels here. So thank goodness the vascular area was sampled, because that was, it provided us the ability to make the diagnosis. And whenever you get a diagnosis of an angiosarcoma or something like that in the skin, we were able to make the diagnosis here in a relatively small biopsy, but you know, sometimes these lesions can be very subtle in the vascular proliferation. If you just had this one blood vessel here, for example, you'd be very hard pressed if you just had a shave biopsy, say, of something like this, to say for sure that you're dealing with an angiosarcoma. So this is a situation where you're dealing with a soft tissue neoplasm that simulated something else for the dermatologist, and they really weren't thinking of an angiosarcoma. You just look at this area right over here, and this looks almost just like a garden variety angioma. Very, very subtle. So be careful of shave biopsies when you're dealing with a soft tissue neoplasm. And if something looks vascular clinically, if it looks weird and if it's broad, if it's on somebody's scalp of an older person, or maybe an area on the arm where a woman's had breast cancer surgery at the area recently, consider doing an incisional biopsy or a deep 6 millimeter punch or something like that. And consider also taking a photograph and submitting it at the same time, because in my experience, when dermatologists and soft tissue neoplasia kind of intersect, the outcome is often bad. I've seen a number of cases of shave biopsies of angiosarcomas underdiagnosed through the years, and it can lead to lawsuits and all sorts of problems, because this is a very aggressive cancer and you don't want to miss the diagnosis. You don't want to delay the diagnosis. So if it happens and it gets delayed, it can be a problem. So just beware of soft tissue neoplasms when you're taking shave biopsies and things like that. So here we're looking at a different type of process altogether. And this is another one. Sometimes we show you things that there's really no way to make the diagnosis. So there's no chance you would know what this is. Without any history, you would never know what it is, but hopefully you can at least categorize it and get it into a category. So here we've got a punch biopsy. So what part of the body are we dealing with? Well, you might say, well, it's got a lot of sebaceous lobules. Maybe it's the head and neck area. Maybe it's the face. But you've got this one follicle here that's still going pretty deep down in the subcutaneous fat. You got a residuum of another follicle here. You've got a horizontal section over here. And we'll go to higher magnification of that. And you can see that it's got a couple of terminal follicles here, but you've got some other areas where there's really no follicles. There's a little bit of inflammation down in here, but we should normally see about 15 to 20 hair follicles in anagen in a horizontal section taken from this area of the scalp. And if you look at the vertical section over here, you should see normally about, 6 or 7 or 8 follicles that are rooted out here. Here we have like 1 or 2 maybe. So this is an alopecia. And you have a very large increase in the size of the sebaceous lobules. And so when you see that, you should say, well, gosh, that's got to be androgenetic alopecia. And there probably is a component of androgenetic alopecia. But there are a couple of things that are a little bit funny for androgenetic alopecia. There's this lymphocytic infiltrate here. That really shouldn't be there for androgenetic alopecia. There's also some smudging at the dermo-epidermal junction. You might say, well, gosh, maybe this could be possibly lupus erythematosus. It's got a lymphocytic infiltrate. It's got some interface change. It's got some effacement of the epidermal rhescia. And then it's got this alopecia. And this is a very interesting type of alopecia that sometimes we see with patients that have connective tissue diseases. And if a patient comes in and they have acute lupus erythematosus, they can get an alopecia areata-like alopecia, which is a relatively acute shedding of hair follicles, and they get this lymphocytic infiltrate commonly, and it looks very much like alopecia areata. But it's not alopecia areata. It's this alopecia that's associated with connective tissue disease in an acute stage, and you can see that with either acute lupus or with dermatomyositis. So this is not scarring permanent alopecia like you would see with chronic discoid lupus erythematosus, where you get marked thickening of the basal membrane zone and follicular plugging and atrophy of the epidermis and a dense superficial deep infiltrate. This almost looks like alopecia areata. So hopefully you all thought, this might be alopecia areata in a patient that's got background androgenetic alopecia, but it's not that. It's actually this alopecia areata-like alopecia that we see with patients that have acute lupus and dermatomyositis. And this patient in this case actually happened to have dermatomyositis. They had elevated muscle enzymes, they had classic features of dermatomyositis, and they developed this lymphocytic infiltrate with this acute alopecia. So if you thought AA in a background setting of the androgenetic alopecia, that's perfectly reasonable. I hope you did think that. If you just thought it was maybe maybe a weird androgenetic alopecia with more lymphocytic infiltrate, that's okay too. But just so you'll know, this is what the alopecia looks like when you have an acute connective tissue disease and they develop an acute shedding of their hair. So it's an interesting pattern, and it's one that you'll see clinically every now and then. It's not all that common, but something that we do see on occasion. Okay, so moving on to case 8. And this is an interesting case here also. Got a couple of different little papules here that they've sampled. And let's go to this one over here. And we're looking in the epidermis, and we see this inflammatory process. It's perivascular, and also it's got cells that are not just purely around the blood vessels. And then we've got, notice that the epidermis is spared. And at low magnification, notice that the cells are very pale. So we've got some lymphocytes in here, but we've also got all these pale cells. So when we think of pale cells, we think of histiocytes. When we think of histiocytes, we think of possibly granulomatous inflammation. And so we're going to go to higher magnification. And let's see if we can tell anything about these cells. And they all have quite a bit of cytoplasm in them. And none of them are multinucleated. And another feature that you might tell in some of the areas, there's a little bit of some extracellular, slightly bluish gray material. It's kind of hard to see in this slide here, but if you go back and maybe look at some of the other images, maybe you can see a little bit of that. But usually it's seen more commonly in this entity than you see it in anything else. So these cells have foamy cytoplasm with an infiltrate of lymphocytes. So the differential diagnosis of this pattern is really kind of almost just 2 things that can do this. One would be eruptive xanthoma, which is what this actually happens to be. And eruptive xanthomas actually are relatively inflammatory. If you see the lesions clinically, they often kind of, they're yellowish, but they can have some reddish color, pinkish color sometimes, because they'll actually get some inflammatory cells in there as well, other than just purely these xanthoma cells. And the other thing that can do this is granuloma annulare. And those can look pretty similar, especially the interstitial form of GA and the extracellular lipid of a really rapidly eruptive xanthoma, one that happens really, really quickly, can look a lot like mucin. And so we don't really have a lot of that change here, but that's the classic differential diagnosis between eruptive xanthoma and also granuloma annulare. So this was an example of a patient that had an eruptive xanthoma that had this inflammatory infiltrate. And again, some of these you'll actually see this extracellular lipid. Now, one thing that's interesting about eruptive xanthomas, they can develop extremely rapidly. Patients can get pancreatitis. They get really high lipid levels of 2,000, 3,000 or even more. And these things can come up literally in the matter of moments, not in seconds, but in minutes. They can just really come up quickly. And when you get their lipid levels down, they can go away very quickly. So they really and truly can be very eruptive. I think we've got a couple of slides here that were done in this case also, just to kind of show you. I believe this first one was an S100 protein stain, which highlighted some of the cells in there. Some of these were probably dermal dendrocytes that were highlighted. And then CD1A also highlighted some of these cells. So I think you had some of this to look at. So this was just, these were highlighting the lipid-laden histiocytes that were CD1A positive. Not that important. Certainly it was not Langerhans cell histiocytosis, but this was a patient that had eruptive xanthomas and had these positive cells in the infiltrate. Okay, this is the next case here, which is case number 9. So we look at this at low magnification, and it's got this very dense basophilic morphology at low magnification. And so you know there are going to be some type of cells in here that are going to be probably maybe some lymphocytes. Some of the cells are a little bit paler in the background here. It looks like it's a nodular proliferative process. And is it inflammatory or neoplastic? If it's neoplastic, it's going to be likely benign. It's very well circumscribed. It's very symmetrical. We're going to see what kind of cells they are. They're going to be epithelial cells or non-epithelial. It's kind of hard to tell at this power. They might be epithelioid. But as you go to higher magnification, you can see that some of these cells, again, there are these inflammatory cells in the background, but then we've got these large multinucleated cells here. And some of them actually have some cytoplasm that's a little bit pale and foamy, and some at the periphery of some of these cells here. So these look like histiocytes, and some of these are histiocytes that have foamy cytoplasm, even more than the last case of the eruptive xanthoma that we just saw. So when you see these cells that have this the histiocytes that are multinucleated, forming this wreath with the foamy cytoplasm within them, we refer to those as Teuton giant cells. And so this is an example of a Xanthogranuloma. Another example of some of these Teuton giant cells over here. And you got all these inflammatory lymphocytes in the infiltrate as well. And sometimes in these cases, when they're really in a super early inflammatory stage, they can get a lot of eosinophils in the infiltrate, especially in children. So if you get a juvenile Xanthogranuloma that's really very florid and inflammatory, don't be surprised if you see a lot of eosinophils in there. These are beautiful examples of Teuton giant cells right here. So hopefully you all thought of this answer. And you know, some of these cells actually here almost look kind of like osteoclast and osteoblast. So if you were going to get this on a board examination, they probably would put that in there. I don't think they would put something that you can also get multiple large histiocytic cells, like, for example, giant cell tumor of tendon sheath or something like that, where you can get some of those large osteoclast and osteoblast-like giant cells. They might put something like an atypical fibroxanthoma, though, on there, because you can get large multinucleated cells in that too, but there's really no atypicality of any of the cells here. And in an atypical fibroxanthoma, you would expect those cells to be atypical with mitotic figures, and you really don't see any of that here. So this was a nice example of a xanthogranuloma. And these do not all have to occur in children. We see these in adults also. Most common setting is in childhood, but obviously they can occur in people of any age group, and we see them in plenty of cases in grown-ups. So, okay, here we've got a very thin shave biopsy. Okay, so very thin shave biopsy. In fact, this consists mostly of cornified material. Let's see if we can look at another piece. There might actually be some epithelium over here. Yeah, this one's got some epithelium. There's the epithelium. Let's turn it upside down. And let's look in the, so here, there's a shave biopsy, and it's very, very thin. So they probably were looking for a neoplasm. Now, this has a teaching point. So what part of the body are we on? We're on volar skin, okay? And a lot of times when you biopsy somebody on somebody's volar skin, maybe they have something that looks like a melanoma or some acral nevus, and you say, well, I'm going to take a shave biopsy of this lesion, and I'm going to really do a deep shave biopsy, and I'm going to really get to the bottom of this thing. Well, this guy took a pretty deep biopsy for him. I mean, he thought he was getting pretty deep, or her, but they just barely got to the bottom of the epidermis. So if we were going to measure this with an ocular micrometer, you know, this might be almost a millimeter thick, but they didn't even get into the dermis hardly. So when you're taking a biopsy on volar skin, beware. You really may think you're getting deep, but because the cornified layer occupies so much of the skin surface, you really may not even be getting down into viable epithelium. And that other piece we just looked at over here was only cornified layer. So if you're biopsying in a melanocytic lesion, beware of sampling error with a shave biopsy. You've really got to almost do an incisional biopsy, or sometimes even punch out the entire lesion and go ahead and bite the bullet and put a stitch in. Nobody likes to punch volar skin area, but that's sometimes what you really need to do to get deep enough to get enough epithelium to get a diagnosis, especially if the lesion's in the dermis. Otherwise, you just may get back a diagnosis of tissue insufficient for diagnosis. Nobody likes that. Well, they were looking for a pigmented lesion here. And so what lives on volar skin? Well, we look for things like, you know, acral nevi, acral melanoma, and there's nothing, at least here, in the epithelium. So what else can give you pigmentation on volar skin? Well, let's look in the cornified layer, and there are these holes up in here, and it may not project all that well, but whenever you get holes in the cornified layer, it's really there for a reason. It's not always artifact. And here, instead of it just being, there's something in there, but it was gaseous. It was actually probably carbon dioxide that got produced by a living organism. And these dark structures that are not projecting super well here, but if you actually were able to look at a slide, are brown dermatiaceous hyphae that are in the cornified layer. You see them a little bit better right here. So as I'm sure you know the answer, since I mentioned dermatiaceous hyphae, you know that the answer is Tinea nigra. And Tinea nigra looks like a brown macular patch on volar skin. We get biopsies of these a few times a year, rule out malignant melanoma, and they often are submitted with a shave biopsy like this, sadly enough. And we can make the diagnosis if we get the cornified layer, but often doesn't even get down into the epithelium. And, you know, theoretically, you get Tinea nigra and a melanoma. So just because we can diagnose something as Tinea nigra, make sure that you haven't missed an acral melanoma. And you really need to take a good deep sample. It samples a representative area so we can see if the presence of melanocytes are there, and if we see that they're dendritic going throughout the entire thickness of the epidermis, or if they're individual melanocytes that are pagetoid, which often aren't present on acral skin. You just want to make sure that you can make sure you get a representative sample. So beware of shave biopsies on volar skin. Okay, case number 11. And this was an interesting case here. Once again, we got multiple pieces of skin here, and let's look at this piece first down here. So it's kind of fragmented, but it is kind of valuable. So What's the process that we're looking at here? We've got a shave biopsy submitted in multiple parts, and we've got some areas of crusting and hemorrhage. We've got this brown material in the dermis here, and then we've got this other area over here. So let's look at the brown area first. So again, we've got a shave. We don't know what's going on over here. The epidermis is gone, but it may be that that actually was shaved and then sort of maybe a deeper saucerization was done. We've got a neoplastic process. It's brown. Things that are brown, we think of melanocytic lesions. We think of, if we're thinking melanoma versus non-melanoma, we look for symmetry, circumscription. We've got this relatively small symmetrical lesion. We don't know really how big it is, but it seems to be symmetrical here. And it's got these spindle-shaped cells. And so what's the most likely diagnosis when we see spindle, heavily pigmented melanocytes in the dermis? Well, we think of a blue nevus. So this part of the lesion looks very much like a blue nevus here. But is that all the story? Well, let's look at this other piece over here. We've got a zone where there's all this necrosis. Now, whenever you see necrosis en masse in a melanocytic lesion, you should immediately be concerned about that. Melanocytic lesions the benign lesions don't undergo necrosis en masse. So they just don't do it. So whenever you see necrosis en masse in a melanocytic lesion, you should say that's very much a red flag that it may be malignant melanoma. And we really can't tell much here because everything's necrotic. We've got this one little area over here to the side. Well, this is kind of epithelioid, and what's going on here? It's really kind of hard to tell. So let's look at this last area up here. That's different than the blue nevus part. And we've got this nodular area now. And it is undergoing this necrosis en masse in this area. And now we've got these epithelioid cells here that are necrosing. They're mitotic figures. So this is a very rare, unusual example of a malignant melanoma arising in a blue nevus. So this is melanoma arising in a blue nevus. We don't see this very commonly, but when it does happen, this is sort of what you see. You'll see an area of normal appearing blue nevus, usually a cellular blue nevus, and then in an area contiguous to it, you'll see malignant degeneration that looks like a melanoma, and it looks different than the blue nevus component. So here you've got this zone of necrosis, you've got the nodular melanocytic component, and if you just had something like this, without having, melanin and some other features like that, you really might not even be sure what the differentiation is here because it's really pretty poorly differentiated, but it actually is associated with this blue nevus component. So we were able to make the diagnosis of melanoma that arose in association with a blue nevus. So that's, again, a fairly uncommon entity. You're probably not going to see something like that on the board exam, but something that you should at least know about. And when it does happen, this is how it happens. There's usually a pre-existing blue nevus, and then you get this malignant degeneration that develops usually within an area of the blue nevus. And it's usually a cellular, pretty large blue nevus when that happens. So hopefully that was educational for you. Several different important points here. Always remember, whenever there's necrosis within a melanocytic lesion, that's a huge red flag. Okay. So this one's a good case also. Small, the biopsy is not all that small. It's just the magnification at this power is pretty low. And so when we bring it up, it actually is, this is kind of what we'd be seeing at probably 2x. We look at the, under the microscope. So here we have a punch biopsy, and it's an inflammatory disease. And at low magnification, we can see it's got a superficial and deep infiltrate. And these cells, some of them are lymphocytes, but once again, not all of them are. And also notice at this power that there's something going on at the interface here. So superficial and deep infiltrate with interface dermatitis. Okay, so that's very helpful right there. When you can put into that category, there's a relatively few number of diseases that can give you that pattern. So you start thinking of differential low power, say, well, okay, lupus, maybe some kind of photodermatitis. The photodermatitides tend to give you a deep involvement, maybe a photoexacerbated drug reaction. maybe a fixed drug eruption. We know that can look, that can give you an interface dermatitis. So again, there's not a whole lot of diseases that give you vacuole or interface dermatitis. So that's kind of the good news. As we go to higher magnification, it's really got a beautiful example of this interface dermatitis with all these individually necrotic keratinocytes here. Okay, so notice these. These are apoptotic, dyskeratotic keratinocytes. These are all burned out apoptotic bodies, cytoid bodies, necrotic keratinocytes, pink cytoplasm with this eccentric pycnotic nucleus. So this is classic what you see with dyskeratotic keratinocytes here. Okay, you see this pattern, you know that the epidermis is dying. So this is an interface dermatitis with this individual necrotic keratinocytes. And here we also have lots of melanophages. And some of these melanophages are deep, go pretty far down. There's some that are, down here in the lower reticular dermis. There's not a lot in this field, but it's not just at the papillary dermis up here. They're getting deeper into the mid-reticular dermis. So when you see deep melanophages, it means that this inflammation's probably gone on at the site over and over again. And another thing, let's take a look at the infiltrate. So clearly a lot of them are lymphocytes, but if you look carefully, there also are some eosinophils in here. That's an eosinophil right here. And in this condition, which is a fixed drug eruption, you get eosinophils. Now, you don't usually get as many eosinophils, say like in a bug bite or something like that, but you usually see some eosinophils. So this is a classic, doesn't get any better than this histologic example of a fixed drug eruption. The only way it might get a little better is if it had a few more eosinophils and maybe it had some melanophages that are a little bit deeper, but maybe this one just hadn't recurred at the same site enough times to get deep enough to give you the deeper melanophages. So this is just doesn't get much better than this for fixed drug eruption. So hopefully you all thought that and you got the diagnosis and you didn't fall down the pathway of one of the other interface dermatitis when you get that kind of pattern. Okay, neoplasm. How was this taken? By a nucleation technique. So this probably was a little ball in the skin, and they probably said, well, this is probably a cyst. Let's take a biopsy of this thing. They probably took a nick over it and out popped this lesion. And it's obviously very benign. Small, symmetrical, well circumscribed, we got all those features. What kind of differentiation is exhibiting? It's got fat differentiation. Okay, so what's the diagnosis? Lipoma, right? So benign neoplasm of fat equals lipoma. 2 + 2 = 4. Nothing to worry about there. You don't have to even think about it twice. But what's a little different about this type of lipoma than most of the other lipomas that we see in the clinic every day? Do most lipomas pop out like a little marble in the skin or a BB? No. So this is a subtype of a lipoma. It's known as a mobile encapsulated lipoma. It's encapsulated because it's got this little fibrous rim at the periphery. It's a real capsule, or it's just kind of the fibrotic dermis. It's kind of to the edge of it there. But these lesions often do kind of move around. And when you actually go to biopsy these, you may kind of have to hunt for them. You say, well, where'd it go after you put your lidocaine in there and you puff everything up and you try to find it? It seems like it's disappeared. But if you do a little incisional biopsy over this, maybe you put a needle in it before you numb it up, and then you just slice into it, they'll just pop out, and it's just a benign variant of a lipoma. So just kind of a gee whizzer, if you will. Just remember that that's a variant of a lipoma, not anything really to worry about, but just something to know about. Okay, here we've got looks almost again like it might be some type of an incision. This looks like somebody had to kind of cut deep into this thing. And what part of the body are we on? Well, we're not sure, but what is this material here? As we go to higher magnification, you can see that there's cartilage. There's cartilage. Now, is this normal cartilage? Well, this part looks okay, but then you kind of get down in here and it sort of starts getting, kind of a little bit more bluish gray, and then it kind of gets eosinophilic, and then over here, it almost looks like it's degenerated and there's a liquid, and then here's some cartilage again. So you have cartilage, oil, and more cartilage. And you got some fibrosis over here. So what if I were to just tell you that this was from somebody's ear, and this area over here looks like a lot of scar tissue. So we've got this degenerated cartilage, we've got this sort of malformed cartilage, we've got scar sitting in here. So what do we think about when we see a zone of cartilage with degeneration, and it's got this liquid, almost mucinous material in here? And if you took a scalpel and poked into the middle of this and pushed on it, an oily material would come out. Well, this is a classic example of so-called pseudocyst of the auricle. And it is a pseudocyst. This isn't a real cyst. It's not lined by an epithelium. And basically what happens here is that the cartilage gets damaged, usually with somebody that gets kind of blunt trauma. They get slugged in the ear by, like, boxers get this all the time. Wrestlers get this, you know, when they're getting put in these head vices and things like that. They get their ears, they crush their ears, they damage their ears, and they get cauliflower ears. So if you biopsy somebody's got that ugly looking cauliflower ear, this is what it looks like in the acute stage when the cartilage is undergoing degeneration. And this is what it looks like in the chronic stage. All the cartilage gets replaced by fibrous tissue, by scar. And so their ear turns into a cauliflower. It's why they call it that. So this is what so-called pseudocyst of the auricle looks like, if you see this. Now, this is not relapsing polychondritis. There, you get inflammation that goes on the outside of the cartilage, gradually degenerates it also, but doesn't give you this oil, and it gives you inflammation there. And that gives you a floppy ear, bloodhound ear, as opposed to the cauliflower ear. Okay, so the last one that we'll do for this morning. Hope this has been enjoyable for you and helpful for you. Learn something from it. So again, we've got what looks like a little punch biopsy. And it's a very sparse infiltrate here, but this is a pretty quick diagnosis. So once again, sparse superficial perivascular dermatitis. If there's any inflammation here, you start looking at higher magnification. And they say, well, there's this solar elastosis here, and there's really not much going in the epidermis, but there's something in the dermis. That shouldn't be there. But what is it? Well, it's this yellowish, brown, almost crystalline structure. And some of these almost look like little, almost coiled or curly Q or curvilinear structures in a couple areas, because these are elastic fibers that have been damaged by a chemical. And this is classic, the little brown, golden brown, banana-like structures in the skin of the dermis of acquired ochronosis. So hopefully you all got that pretty straightforward. Here's another one over here, a little better banana-shaped structure. These aren't quite as well developed as the others yet, but they're all turning in that direction. And you all know I would recommend knowing the biochemistry of this issue. This is basically creates this abnormal elastic tissue that becomes this acquired ochronotic pigment, usually due to application of hydroquinones. So hydroquinone causes abnormality in the elastin. It undergoes this basic polymerization. It precipitates, if you will, in the skin, and then it actually gives you these little brownish papules. So the people want to make their skin light, and notice that there's no melanin up here in the epidermis, so they probably accomplished that, but they got these brown papules that develop when they got the acquired ochronosis. So that's from applying long-standing hydroquinone to the skin. I would also recommend knowing the non-acquired ochronosis pathophysiology of homogentisic acid pathway. Just make sure you know a little bit about that, because the board could ask that question. And that gives you abnormalities in cartilage and elastic tissue inside the body. So they get abnormalities with their sclera, they get aortic problems, they get arthritis. But this process just gives you these little papules in the skin. Okay, well, I hope everybody had a good, enjoyed this. And the next time we do this, we'll probably put some clinical photos in. I encourage you to look at these, to test yourself. And one of these days we'll be in a position where we can sit at the microscope and call on you and get you to answer questions and hopefully, learn from this. So thank you guys for listening, and we will see you. I think we'll probably do this in a couple of weeks, then we'll start some thematic stuff going on sometime in the next week or two as well. Take care.